Well, as an interventional cardiologist, I feel like a medical resident up here. I'm learning a ton, which is great. So next we'll have IABP and shock, and Andrew Civitello will talk to us about the kinetics and the cannulation strategy.
And a long journey all the way from Texas.
All the way from Texas. Dr. Carr likes to see me squirm. So I was given the assigned topic of intra-aortic balloon pump counterpulsation and shock. Do kinetics differ based on cannulation strategy? And after realizing that there's absolutely no data with which to answer that with any degree of certainty, I've decided that the assigned topic was the victim of a forced acronym, and what we're really looking at is intra-aortic balloon pump and shock. Do outcomes differ based on cannulation strategies? So I'm going to focus on that. In deference to the assigned talk, I'll struggle through a little bit of kinetics of balloon pump counterpulsation. We'll talk about cannulation strategies and rationale for axillary balloon pump cannulation, and we'll end up with some outcomes associated with axillary balloon pump. We have a diverse audience. I thought I'd start with the overview of balloon pump function. So remember, the balloon inflates in diastole. It augments diastolic pressure, increases mean arterial pressure, and increases coronary blood flow. It rapidly deflates in systole, which leads to decrease in left ventricular end diastolic pressure, aortic pressure, and myocardial work. Intra-aortic balloon pump kinetics have been evaluated using waveform intensity analysis, which clearly shows that during balloon pump inflation, there's generation of a backward compression wave, which, if you will, forces blood backwards to the heart, which is how you increase diastolic pressure and coronary blood flow. Waveform intensity analysis has also shown that during balloon pump deflation, you generate a backward expansion wave, which in effect pulls blood away from the heart and lowers the aortic end diastolic pressure and therefore LV work. The diastolic augmentation of blood pressure and coronary blood flow has been attributed, at least in part, to something called the Windkessel effect. This is an attempt to describe the accumulation of potential energy in the elastic aorta that is released as kinetic energy during diastole. This has been described using very complex electrical circuitry analogies, very complex mathematical equations. It is named after a 18th century firefighter device that used an air kettle to help force out air and increase the pump flow. I like this video that helps explain the Windkessel effect. So we see here we have a pump, and the pump is pumping, and we have flow during ejection only. Now, if we add an elastic chamber to that, you can see that we have flow continuously, both in systole and diastole. So I think this helps me at least understand the Windkessel effect and the balloon pump augmentation. So let me summarize my brief little discussion about kinetics. We have a backward compression wave and augmentation of the Windkessel effect that augments diastolic pressure and coronary flow. And then we have a backwards expansion wave that decreases end aortic pressure and decreases LV work. Now I'm going to switch gears and talk about cannulation strategy. So balloon pump was first implanted in 1968. It was a surgical procedure via the femoral approach. 1980, we had the first report of a percutaneous insertion of a balloon pump through the femoral artery. In 2013, our good friends at the Methodist Hospital, including Jerry Eastup, wrote a very elegant article describing the safety and efficacy of implanting an intra-aortic balloon pump via a percutaneous approach using the axillary artery. There's been a huge resurgence in the interest of intra-aortic balloon pump counterpulsation as a bridge to heart transplantation, really as a consequence of the change in the 2018 heart allocation policy. Patients on intra-aortic balloon pump support are currently on equal footing with a patient with a failing LVAD, a pericorporeal LVAD, patients with significant ventricular dysrhythmias, patients with mechanical circulatory support due to a single ventricle, and patients with all manners of percutaneous endovascular support. And this has really led to an uptick in balloon pump insertion. So in the year prior to the policy change, there were 221 patients in the UNOS database supported with a balloon pump as a bridge to transplant. That went up to 822 in the year after the policy change. There are a lot of centers and operators that are very interested in using axillary cannulation so that the patients can ambulate while they wait for heart transplantation. So we're going to shift now to outcomes based on cannulation strategy. I was asked to talk about kinetics. It's important to remember that the balloon pump is a symmetrical device. It doesn't know north from south. There's really, empirically, should be no difference from a antegrade versus a retrograde cannulation strategy if the balloon is in the proper location and if it's timed properly. Remember, when you go from the axillary approach, the optical sensor is now about 30 centimeters more distal in the aorta, and I think this could potentially lead to a late deflation error, which is a hemodynamic disaster. Also remember that patients with axillary balloon pumps have a unique set of potential adverse effects, right? So these pumps tend to migrate. This is a series of x-rays showing an intra-aortic balloon pump that has folded back in the ascending aorta. The reason to put these devices in is so that patients can ambulate as they move around. The pumps tend to migrate, so you need to watch these patients very, very carefully. Also remember, you're going through a very tortuous group of arteries, and kinking is more of a problem with axillary cannulation. Let's talk a little bit about hemodynamics. We have two data sets to draw upon. The Methodist Hospital group, we have Dr. Bemiraj here, and the University of Chicago group. The Methodist group has shown increases in improvements in right atrial pressure and mean arterial pressure with axillary balloon pumps. The Chicago group has shown improvements in central venous pressure, mean arterial pressure, wedge pressure, and cardiac output. And these are all at about the level that you would expect to see with femoral cannulation. We look at complications. Remember, there are special complications with axillary cannulation. In the Methodist Hospital cohort, 195 patients, 37% required balloon exchange or repositioning, 16% developed a vascular complication. University of Chicago cohort, 28.6 required balloon exchange and 15% developed a vascular complication. It's very hard to find a comparable cohort, but the most recent femoral extended support cohort was in 1997. 23 days, 32% had a vascular complication, and 38% required at least one exchange. So although axillary pumps are not perfect, they actually fare fairly well compared to the historical femoral balloons for extended support. The real clinical question is, can you support these patients to a transplant or a VAD? The Methodist Hospital cohort, 68% successfully went to cardiac replacement, most going to transplant, less going to VAD. University of Chicago supported 92% with an axillary balloon pump to a transplant. So in summary, axillary cannulation for balloon pump support is feasible and relatively safe. Support via axillary cannulation does show improved hemodynamics similar to femoral cannulation. Percutaneous axillary balloon pump cannulation is a feasible strategy for bridging to heart transplantation, and patients on axillary balloon pumps require close monitoring for adverse effects due to the unique cannulation strategy.
Wow, Andrew, there is a lot to talk here about. And IJ, maybe I will ask you first, because we start talking a little bit about, even when you do subclavian or axillary, there is two ways to do it.
Yeah, I mean, we were talking a little bit about, fully percutaneous versus doing it with a graft or some other sort of in the OR. Tell us a little bit about your experience, and then I'd love to hear from others on the panel, because at least in our experience, the pure percutaneous approach, depending on the type of sheath and the pump that's used, can definitely be prone to ruptures, migration, and that sort of thing.
Well, I hate to steal Dr. Bemiraj's thunder. He's the expert. I can tell you that the University of Chicago group, 70% of those were placed via a graft. And in the Methodist group, 100% were placed percutaneously. And actually, it looked like there was less vascular complications at the Methodist Hospital. I think it's very operator dependent, but I'd love to hear what Arvind has to say.
Arvind?
Well, I think, as Andrew mentioned, we've been lucky since 2013, 2011. Guillermo kind of started doing it Texas style, cowboy style, just do it and figure it out. And then it worked well. And I think, to Andrew's point, in our experience, there's a bunch of nuisance you have to deal with, which comes with the turf, because the device is not built for this when you do an axillary. The problem with the graft is some of these patients, we've actually lost a few because you put them under anesthesia, do a vascular procedure. That's enough risk for some of these tenuous patients. We also had a few graft-related infections before. So in our cohort, I think it's worked out well. There are a few patients that we ended up, because of multiple exchanges, did a graft on the right side, we do percutaneous mostly on the left. With the graft, you're right, it doesn't move much at all.
So let me wear my hat of Chicago, because this is our paper. So when we started, because we were following actually what you did here in Methodist, that was actually the motto to transition to the balloon pump. And I remember I spoke with Jerry Estap during that time, but we decided it would be easier for us to start with the graft. And Val Givanandum, together with David Onsanger, our surgical team, was doing the graft. We loved it. And I agree with IJ, there was much less transition. However, exactly like what you mentioned, the challenge is that those patients go to the OR in order to get those grafts. And another challenge, after the transplant, they left with a graft. And we have one patient that we had to do a mega surgery after the transplant just because of infection of the graft. So that's something can happen. And then we transition. And the reason that you see 70-30%, all the recent period of time is actually completely percutaneous, IJ. So we move from the graft to complete percutaneous. Now when I came back to Colombia, I have to say we're going through the same process, because I think there is a learning curve to do a complete percutaneous. I want to challenge you, Andrew, with another thing that always is a big fight. Right or left?
Always left.
Always left.
Always.
Always
David,
left?
Always left.
David, you have
Left.
a ton of experience.
Always
here.
left.
Always left.
If possible.
Percutaneous for you,
Yeah.
right? Dave. Well, actually, how about a show of hands from the panel? Percutaneous, axillary,
Absolutely.
graft.
What we do? Yeah. We do all grafts, 100%.
Wow.
But what we do isn't necessarily what we should be doing. I mean, in general, for everything that's ever been on the panel
I will
today.
say, though, the nuisance issues, there definitely is a range for improvement of the percutaneous approach. And I think that if there's some innovation there, that might solve some of these issues.
There's a comment, the sensor balloons, they have a lot of problem with the axillary. So they use the older generation balloons. So can you comment on that specifically?
Actually, that's very important. The sensation balloon, which is a newer one with the sensor, early on, we've had a lot of, it's very floppy.
Yes.
So we don't use that at all. For axillaries, we just use the linear, which is an older version.
I would just make one comment that there's next month, probably coming out in J-Sky and possibly one of the other JACC journals, there's a consensus document from Sky, the co-chair along with Dr. Arnold Cito, all about percutaneous and axillary access for procedures, from how you do it, and our task force included vascular surgeons and others. So just waiting on one final thing before that endorsed document is published.
One question from the audience.
Question. So we all weekend have been talking about going away from intra-aortic balloon pump for cardiogenic shock support, and we have saying all these patients come from outside hospital with balloon pump, and we are switching already to something else because get them more support. So when will you pick up intra-aortic balloon pump, axillary intra-aortic balloon pump when you have an Impella 5.5? What makes you go to intra-aortic balloon pump instead of an Impella if the decision is to mobilize the patient and give them support at the same time, longer support?
The question is about when to escalate?
When do you use
when
one
do you
versus
pick
the
up
other?
one or the other? If you are saying that
yeah,
balloon pump is the less support right now.
At least I'm a big believer in using the least invasive thing that achieves your goal. So I think if you can achieve the goal, the hemodynamic goal with a balloon pump, a balloon pump's absolutely fine. If you can't achieve the goal, then you need to escalate therapy. So I think, at least in my mind, the bigger question is, when do you pull the trigger on an LVAD in these patients that are sitting around in your ICU waiting for transplant? And that's something that we all struggle with. So,
Andrew, you're raising now a really, really great point. There is a dynamic field. Like when the new allocation system started, you can transplant those balloon pump status 2 within days. Right now, they can sit 6, 8 weeks, and even more. And they became sicker, and they may lose the window for other heart replacement therapy. So it will be interesting. I saw that already 2 of the panel on the left. Maybe we'll start what you do here in Hermann Memorial and then what you do in Northwestern.
You go first.
No, I think the point which Neer is raising is very important, because in the new allocation system, the paper just came in JACC heart failure. Only 3% of the patients were transitioned to durable MCS in 30 days. So that is a phenomenally low amount. So you're basically saying that there is no concept of LVAD as BTT. There's only LVAD as destination therapy, or rest all go through a cohort of just putting them through transplant. So I think they have to change the allocation, and you cannot compare intra-aortic balloon pump with percutaneous MCS as a status 2. It has to be a different status altogether.
Very good point. Thank you.
I was also going to say one thing. I think it's too simplistic to say we're moving away from the balloon pump. I actually think there's great data out of Columbia, not randomized, that showed particularly that there was an effect difference between ischemics and acute shock versus non-ischemic shock, and there's a higher percentage of people who are these super responders. So I'm also simplistic about it. I get away with the least amount possible, and the balloon pump is a lot less than all of the other stuff we're talking about. But I think everywhere we're seeing BTT VADs kind of fall by the wayside, and I think we constantly hear in our meetings that we are putting patients at risk to give that delaying a potentially life-saving therapy to get them to transplant. And I think when to pull the trigger is very difficult. The new allocation system does require every 2 weeks to resubmit if there's an exception or anything. And half the people have exceptions because their blood pressure was 92 instead of 89, let's say. So, but I think the allocation system needs to change as well.
So
it just won't anything.
But to refer to the paper, that when we look at the Intermax and we saw that people doesn't use it.
Yes.
Exactly like Esther said, everybody find an excuse to get an exception, and you need to say why that the patient after 2 weeks is not a candidate for mechanical circulatory support. And I think there need to be eventually, this allocation system is going to find a new balance. It's temporary until there is going to be a score, but right now we need to be careful not to lose patient on the list with the balloon pumps.
But Neil, I do want to point out that the waitlist mortality was not increased in this system.
No. Yeah, but it's...
So I think this is a whole day conference debate we can have, but I think it's a balance. I don't know where we'll end up. The system probably needs to make it more advantageous for VAD patients to get a transplant, because once they get a VAD, they become at a disadvantage. But with MCS, the waitlist mortality has not increased.
David, last comment.
So I could tell you one thing, that if I have a paper pending with JHLT, if you look across the world, because we think that we're unique in the United States, but these problems come up everywhere. For example, in Spain, if you look at the nice paper about their urgent allocation, they specifically note that balloon pump was removed about 4 months after it was added, because they noticed an immediate incredible rise in the number of people using a balloon pump. So in those other countries, and same in France and other places, balloon pump, these theoretically easy devices, are absolutely excluded from urgent allocation, because they understand that still most people won't put somebody on ECMO unless it's absolutely necessary. So this problem of mysterious growth in balloon pumps is not unique to the United States. But our response is unique in the fact that we continue the advantage.
So Andrew, first of all, thank you very, very much.